So a few final slides. Effect on respiratory, on obesity on respiratory intervention. So something down, a little bit more down my alley. So a very quick slide. Basically, when you go into the hospital and you need to perform procedure, a very quick, busy slide, but if you do a bronchoscopy when you're obese, you are far more likely to have early termination of bronchoscopy because of intolerance, a lot more bronchospasm, a lot more drug or sedative that you need to use, and they take a lot longer to recover. For transthoracic procedure, whether it's CT-guided FNA, pleural tapping, pleural ultrasound procedure, any complication is significantly more. And failure of procedure, especially in the morbidly obese, are significantly more. It's 13% to none. And this is usually due to simply the design of the instrument. This instrument is simply not long enough to go through really morbidly obese patients. For a patient that comes in with emergency intubation, disease requiring emergency intubation, death is 4% versus 0, cardiac arrest is 11% versus 1 from the emergency intubation, and severe hypoxemia is also significantly higher. And PBC, we're talking about post-operative pulmonary complications. So after operation, patients with obesity have significantly more stridor afterwards, more atelectasis, more ARDS, acute respiratory failure, more prolonged ventilation, and therefore more ventilator-associated pneumonia. So the last part I want to answer very quickly, the question, which is the cost. It's a very difficult question to answer because we don't have a direct number. But if we jump a bit around, we can see from here. Now, if we take the US data, they have a prevalence that is slightly higher than us, and their undiagnosed rate is slightly more. So we have less undiagnosed OSA. Just talking about OSA and the cost, in untreated, if we allow this conversion of money, then per patient, the cost of undiagnosed and untreated OSA comes in around $50,000 Hong Kong per patient. And this is mainly from the cost from comorbidity, car accident, car loss in productivity. So this amounts to around 500 million Hong Kong per year if we take the longevity of the disease. In treated patient, then we take into account all this and mirror that, and this is 116 million per year. Message here, it costs a lot of money, but of course, it's still cheaper to treat than not to treat, obviously, but it costs a lot of money. Even more difficult to calculate it from the OHS population, but suffice to say, it costs, not only that they cost a lot more than general patient with OHS actually costs a lot more to the healthcare than just obese patient by the same BMI. So they cost significantly more. These are UK studies and Europe studies. And finally, we cannot find any studies on cost in this arena for asthma, but we can see from the previous discussion that it brings the asthma into better control. And when you have better control, the direct and indirect healthcare costs from a better control asthma significantly improved. So this is the biggest and the no-no slide and the last slide that I have. If we build the assumption upon assumption upon assumption upon assumption, then we sort of get this. So if we have the weight reduction, that leads to the decrease in the severity and some of the incidence of the diseases, and we calculate it with the caseload, potentially there are significant cost reduction in treating, in managing obesity in terms of respiratory, in the realm of respiratory medicine. And I think that's all the time I have.